We will first start with Dr. Sarvani Ghosh-Laskar, who shall be, Madam shall be speaking about planning in CA larynx. Madam, kindly proceed.
Thank you very much. And I thank the team at West Bengal AROI and Abhishek in particular for this kind invitation. And what I will try to do today is speak only about larynx and not about thyroid, because to me, thyroid is not just about anaplastic thyroid. We need to also know the role of the radiation oncologist about differentiated thyroid cancers also. So I will be concentrating and speaking only about cancer of the larynx. And I have also been given the mandate to speak about conventional radiotherapy planning. So let's get started. I hope you can see my slides. Yeah. Can somebody tell me whether you can see the slides? Therapy planning.
Yes, ma'am.
Okay, fine. Thank you. So let's begin. So this is essentially the flow of the presentation. Begins with the anatomy. We'll talk about the protocols, talk about the staging workup, talk about simulation, radiotherapy portals, and dose prescription. So coming to the epidemiology of this cancer, for all students, it is very important for you all to note the difference between laryngeal and hypopharyngeal cancers. If you remember, and if any of you have read the Globocan before this, that is the Globocan 2018, you would have realized that actually hypopharyngeal cancers were much higher than laryngeal cancers in our country. However, there seems to be a kind of shift. But you have to remember that the shift is mostly for supraglottic cancers and not so much for the glottic cancers. But in addition to the incidence, you also need to know sorry, I'll just go back. I can't move my slides. Yeah. So I will be trying to cover all these issues in the next 15 to 20 minutes. So please feel free to ask questions once I have finished the presentation. So as I was saying, it is important for us to know the epidemiology of laryngeal cancers. And to those of you who would have read the Globocan before the 2020 Globocan would have noticed that now laryngeal cancers are higher in incidence than hypopharyngeal cancers. But in addition, what you also need to note and document is the mortality and morbidity associated with the cancer. So the most somebody seems to be muting me again and again. Abhishek, hello. Hello. Can anybody hear me?
Madam, you are audible.
Yes,
Yeah, but you know, as I'm talking, somebody is muting me because that's what the screen is showing, that the host has muted you. Abhishek.
Yes, you are audible, madam.
Hello.
You are audible, madam.
Okay, then will somebody indicate to me as and when I'm not heard? Somebody hear me?
Madam, you are audible.
Yes, you are
Yeah,
audible.
but you know, as I'm talking, somebody is muting me because that's what the screen is showing, that the host has muted you. Oh, there seems to be a lag also. Wonderful. Anyway,
You're audible, madam.
hello.
You're audible, madam.
So
Okay,
I'll just
can somebody
continue.
indicate to me as and when I'm not heard? Anybody hear me?
Abhishek, what's happening? Why am I hearing my voice?
Ma'am, you are perfectly audible.
No, but what is happening is whatever I'm talking isn't playing back.
Uh,
It's very funny. Anyway, let's continue.
it must be a technical glitch, ma'am. Can you, if this continues, can you just leave and rejoin once?
I'll do that. I'll do that. Fine. Fine.
Thank you,
So
ma'am.
let me just continue now, for now at least. So we need to remember that world over, the most common subsite within the larynx is the glottis, followed by the supraglottis. And of course, the most common histology is squamous cell carcinoma of the larynx, though we do sometimes get some of the uncommon histologies like neuroendocrine tumors or sarcomas. And as I said before, we do realize that the incidence of laryngeal cancers has increased now. Now, the other important thing, of course, for students is to also know that there is a male preponderance. It is higher in the older age group. And of course, laryngeal cancers are more a disease of the West. And the mortality rate is higher in the older age group for various reasons associated both with the disease, the treatment per se, and the sequelae to treatment. So this is something that we need to be aware of. Now, the clinical presentation of most patients with laryngeal cancer would be a hoarseness of voice, sore throat, dysphagia, sometimes odynophagia, a foreign body sensation in the throat, otalgia as referred pain, loss of appetite, weight loss, halitosis, and of course, neck swelling depending upon the stage and the subsite of involvement. Now, coming in short to the anatomy of the larynx, I will not spend too much time on this because you have a full session on radiological anatomy. What we need to be aware of when we're undertaking any kind of radiation therapy for the larynx is the anatomy, the structures that you would see on an indirect examination or on a Hopkins examination. So superiormost would be the hyoid bone. Then you would also have the epiglottis, the thyroid cartilage, the aryepiglottic fold. The aryepiglottic fold best seen when you're looking at it with your mirror. The vocal cords, the arytenoids, the oblique and transverse muscles, and of course, most inferiorly in the larynx, the rostrum would be the cricoid cartilage. This is, of course, an endoscopic view of the laryngopharynx. So you have the arytenoids, the interarytenoid area, the true cords, the false cords, and the paraglottic space, the epiglottis, the piriform sinuses on both sides. And we need to be aware of this. We need to know what exactly is happening and what exactly is it that we are seeing and what are the structures that are involved. So what we need to understand when we are doing this kind of an examination is to look at and document the mucosal extent of disease, paraglottic spread, and the status of vocal cords, best seen on indirect mirror examination or Hopkins, or while reversing the patient when you have induced him or her for a dialscopic evaluation. Now coming to the patterns of spread. So if you look at it, I spoke about the structures that you see in the larynx. So for supraglottic laryngeal cancers, in the horizontal direction, it will obviously involve the pre-epiglottic space. In the vertical direction, it would involve the paraglottic space, and infiltration of the laryngeal cartilage exhibits features of aggressive growth pattern, and the thyrohyoid and hyoepiglottic ligaments are essentially effective barriers, and they would not allow the spread of the disease beyond the supraglottis. Now coming to glottic cancers per se, vertically, of course, it could spread to the supraglottic structures, inferiorly to the subglottis, and on the contralateral side to the opposite vocal cords. Now, in the subglottic cancers, it spreads into the paraglottic space through the conus elasticus. So this is how it would spread, and higher propensity for cartilage involvement, and there is a higher chance even of submucosal disease extension. Hence, in these cancers, it would be important for us not only to have a mucosal evaluation, but also to have appropriate imaging to know the exact extent of tumor. Now, patterns of nodal spread after the primary. So what we need to know is that no barrier separates the laryngeal system into superior or inferior areas. Both mucosal and submucosal lymphatic vessels are seen to cross in the midline, and lymph fluid of the supraglottic and glottic regions flows to the level 2 and 3 lymph nodes. So if you look at this particular paper, which was a systematic review and describes the incidence, or rather the propensity for lymph node metastasis. So by subsite, as the stage increases for glottic cancers, the percentage or the propensity for lymph node involvement also increases. But what you need to be able to compare and understand here is that stage per stage, the incidence of lymph node involvement would become higher for T1, T2 glottis versus T1, T2 supraglottis. But as you go to the higher stages, of course, the incidence of lymph node metastasis, both for glottic as well as supraglottic cancers, would be very high. And that is essentially because of involvement of the glottic cancers, by the glottic cancers of lymphatic rich areas in the supraglottis. Now, this is a much quoted paper from Clifford Chow, and this can be used for any primary in the head and neck. What I would like for you to note here is the involvement of the various levels of lymph nodes, depending upon whether the neck is clinically negative and or positive. And this clearly shows you in early stage glottic cancers, when it is N0, the chance is lower. But as for supraglottis and for glottis, as you get lymph nodes, the chances of level 2, 3 involvement is the highest. Now, it is also important for us to understand the incidence of contralateral lymph node involvement, and especially so for supraglottic cancers. And even in glottic cancers, essentially because most of these cancers, when we do treat them, we treat bilateral neck. But in the glottis, especially for early stage, there may be room for not actually treating the neck, especially in early glottic cancers, depending upon the extent of disease. So these are certain basic principles that we need to understand for laryngeal cancers. Now, coming to the staging workup, it begins with a careful history taking and clinical examination. Physical examination would involve doing a good examination of the neck, indirect laryngoscopy, direct laryngoscopy, Hopkins, or examination under anesthesia to document the exact extent of mucosal involvement and involvement of the various structures within the larynx. Laboratory investigations are essentially done to understand the patient's general condition as well as the functional reserves of the patient. The biopsy from the primary site is essential to clinch the diagnosis and to be able to treat the patient. And of course, you have to also document the functional status of the larynx. And this is one such functional evaluation, that is the penetration and aspiration scale. In addition to this, if you look at the ESMO in day-to-day practice and the various guidelines, you need to assess the disease status both locally and regionally. And here we would usually, the first step would be a contrast enhanced CT scan of the neck and or an MRI. And as I've already said, you would do a mucosal evaluation first in the office and then under anesthesia. In certain cases with very advanced disease, involvement of low neck nodes, extension to the superior structures, we may want to do an FDG PET to rule out distant metastatic disease. Now, the role of imaging essentially is to understand the extent of the disease both at the primary and nodal sites, decide treatment, prognosticate, understand involvement of the cartilaginous framework, look at extralaryngeal soft tissue spread, and suitability for non-surgical organ preservation. A three-dimensional assessment is important again to establish volume of the disease, decide on treatment, and prognosticate. And most importantly, as I've already said, functionality and suitability for organ preservation are important considerations when we are talking about the management of the patient. For the primary site, imaging assessment can be performed prior to biopsy, especially when there is a strong suspicion of a malignant growth. And for this, it would be a CT scan to understand the extent of disease, pre and paraglottic spread, exolaryngeal spread, and cartilage invasion. And MRI is usually used as a problem-solving tool, essentially because of the motion artifacts that can happen, and also because it is a much slower study as compared to the CT, and in most cases, a contrast-enhanced scan would be able to tell you the exact extent of disease. For nodal metastasis, usually a CT scan, whichever imaging is used essentially for the primary site. For distant metastasis, if it is suspected, we would do a PET CT, or in several cases, you could do an NCCT of the thorax to rule out metastasis to the lungs, or in high grade, or a different histology, or multiple lymph nodal involvement in the neck. PET CT scan may be preferred if you have access to the same in the recurrent setting after chemoradiotherapy or for distant metastatic evaluation. So these are various images where you have a growth in the, and to show you the various structures that are seen on the CT scan, but I will not spend time on this because we have a radiologist speaking to us later. Now, what we need to understand is which do we refer, why do we prefer a particular diagnostic imaging modality? So essentially, it is to be able to identify the extent of disease, to understand which would pick up subtle involvements and which would also dictate the management in this patient. So if you look at what is better, PET CT, CCT or MRI, most studies say that for the run-of-the-mill cases, a CECT should suffice, but when there is any doubt about early erosion of the cartilage or early erosion into the paraglottic spaces or early extralaryngeal extension through the soft tissues, an MRI may be helpful and give you added advantage over a CT scan, but in most cases, otherwise the CT scan should suffice. What about the role of FDG PET CCT compared to conventional imaging and prognostic? This paper essentially is a study to investigate the diagnostic accuracy of PET CT and the value of PET CT to predict survival. So of course, what it helped was that it did identify metastasis essentially in uninvolved neck nodes which were not apparent on clinical evaluation or on CCT. And if you did detect metastasis, especially based on baseline metabolic tumor features, it could also add prognostic value. And this is the same paper again. If you look at it, the biggest value of PET CCT, of course, is in its negative predictive value. And it did also tell us where it was most sensitive for and detecting what level of lymph nodes. So if you look at this, what it clearly tells you is that the impact of FDG PET on staging management following conventional workup, essentially it is best. It could upstage in about 13% of cases. It could downstage in about 7% and inaccurately change stage. So that means it may not be reliable in about 6% cases. And actually, it may not actually impact on management in the kind of indications that I have spoken about. Now, this is the TNM staging, and I will not spend time on it, but suffice to know that we have to know the extent of disease, involvement of number of subsites within the larynx, extension to the paraglottic space, pre-epiglottic space, and involvement of the cartilages of the larynx. And of course, in stage 4, you have tumor that would invade the outer cortex of the thyroid, invade the tissue beyond the larynx. And for very advanced tissue, the disease, of course, it would invade the prevertebral space, or in case the carotid, or invade mediastinal structures. Now, this is for the various subsites within the larynx itself. And this is the end stage. Note the N2A and the N3B stages, which are different from the 7th edition. And this also about the pathological end stage. So you need to know about this. And this is the stage grouping. So any N1 disease actually would become stage 3, and thereafter it would become stage 4. So coming to the management algorithms, stage 1, 2 supraglottic larynx, you could either do a conservative laryngectomy or use external beam radiotherapy. The choice of treatment modality is dictated by the anticipated functional outcomes and expertise available, the patient's wishes and profession, reliability of follow-up, and general medical condition. And of course, the management of the neck is dictated by the risk of occult nodal spread, which we have already seen earlier. Now, if it is stage 3, that is, it is either a T1, T2 with an N1, that is the early stage 3. It would depend upon what is the status of the patient. So here we would really assess what the patient should be considered for, depending upon the functional status of the patient, the performance status, and the age. If all this is intact, we can consider conservative what you call organ preservation protocols. But if it is not intact, then you would have to consider concurrent targeted therapy with radiotherapy, altered fractionation radiotherapy. And if a patient is not a suitable candidate for either, or has a dysfunctional larynx, then you may consider this patient for surgery. And in the presence of any adverse features, consider radiotherapy alone or radiotherapy plus chemotherapy in the adjuvant setting. And the adverse features, of course, include extracapsular nodal spread, advanced nodal disease, positive margins, advanced T-stage vascular emboli, perineural invasion. So on goes the management of stage 3, the T3 tumor. Again, it is important to assess the laryngeal function, and then based on whether it is intact or not, or whether the patient is suitable for concurrent chemotherapy, further treatment would be determined, and it follows the same line therefore. Okay. And post-op radiotherapy should be initiated within 6 to 8 weeks from surgery or as soon as the wound heals. Coming to stage 4 larynx, that means you have nodal stage above N1. Again, here it is important to assess the functionality of the larynx, but this functionality is essentially if you have cartilage involvement or functionality is compromised, then in these patients you are definitely going to let the patient up for surgery. But if it is intact, because it is T1, T2, N2A, N3, you may consider organ conservation protocols, and depending upon the same algorithm, you would then consider concurrent CTRT or altered fractionation or concurrent targeted therapy depending on the functional reserve. Now, if the laryngeal function, it's a T3N2A, again there is scope and follows the same lines. Or there is a scope for perhaps using induction chemotherapy, but we won't discuss all that because it won't give us time for discussing the management algorithm. Now coming to stage 4, that is T4 disease. What do you do? In these patients, of course, you would do with extralaryngeal soft tissue involvement, cartilage not involved. You could consider doing any of these schedules. But if it is compromised or the cartilage is involved, then you would want to do surgery with appropriate neck dissection, and in the presence of any adverse features, adjuvant therapy. And if, of course, patient is not fit for surgery, palliative radiotherapy or any form of palliation. Now coming to glottic larynx, T1, T2, EBRT using small fields or conservative laryngectomy. The goals of therapy here are, of course, cure, laryngeal voice preservation, optimal voice quality. For any stage more than this, of course, the management becomes somewhat similar to supraglottic larynx. There may be difference in the type and extent of surgery, and this, of course, would be determined by the location and extent of disease. These are the ESMO-ASTRO guidelines for the same thing. I won't go into details, but essentially they follow what I have already told you, and that is essentially the NCG guidelines. Now, coming to the treatment volumes. Now, you have seen where we are going to use radiotherapy, the stage where radiotherapy can be used alone or can be used in combination with chemotherapy, and the aims. The treatment volume is determined by the stage of the cancer, the T stage, the propensity for lymph node involvement, extent of disease, and the setting, whether it is adjuvant or definitive. Now, coming to GTV delineation. Now, accurate delineation of the GTV is critical and crucial, and what all of us have to remember and what the guideline paper actually emphasizes is that it has to be a combination of clinical and imaging data. Clinical examination of the pharyngolarynx with fiber optic examination with a detailed description of the tumor extension and infiltration is absolutely necessary. You may want to draw diagrams, take photographs so that you can document all this. Also, when we want to delineate the tumor or understand the extension, we should do a contrast enhanced CT scan and MRI. A diagnostic CT may also be useful, especially if the position is not too different from the treatment position, and diagnostic imaging may be fused with the planning CT to do so. So this is a picture showing you the extent of disease in the glottic larynx, extension to the paraglottis, and there seems to be disease on both sides of the thyroid cartilage, and it could possibly be a T4 laryngeal cancer. Now, PET fusion, what is its role? It is usually not recommended in the definitive setting, and especially so for small tumors due to the lack of spatial resolution with partial volume effect. Now, coming to the delineation of the clinical target volume. Now, I have a word to say here. I know I'm supposed to do only conventional radiotherapy, but what I would like to emphasize, and that is why I'm alluding to this topic, is because the target volume, whether you're doing 2D, 2.5D, 3D, or IMRT, remains the same. Essentially, what I'm trying to say is what you need to treat to cure the patient, that volume will remain the same. You are going to treat the primary volume, you are going to treat the nodes that are involved, and the elective lymph node areas. So that is why it is important to understand that these volumes are now different. What conformal radiotherapy or IMRT just enables you to do is better sparing of the organs at risk. So of course, all of you must read this paper on delineation of primary tumor clinical target volumes in laryngeal, hypopharyngeal, oropharyngeal, and oral cavity squamous cell cancers, which is a consensus guideline. So it has proposed several nomenclatures. One is the GTVP, which is the GTV primary, then the GTVP1, which is the CTVP1, which is the CTV associated with the high dose prescription, and it is a 5 millimeter margin edited around the GTVP. The CTVP2 is associated with a lower dose prescription, the so-called prophylactic or intermediate dose prescription, and this should correspond to the GTVP plus a 10 millimeter edited margin. CTV is not a straightforward geometric expansion to GTV and needs editing. Please remember that. Actually speaking, the CTV is a biological concept and not a geometric concept. And how do you edit this? Adaptation for air cavities, adaptation from the complex head and neck anatomy, adaptation for strong anatomic barriers, and take into account the experience gained from surgical series. Now, this is a T1 glottic cancer. So the CTV-P1 will be the GTV plus an isotropic margin of about 5 millimeter in all directions. It would include the paraglottic space, the anterior commissure of the vocal cord, the vocal process of the arytenoid cartilage, the subglottic and supraglottic aspects of the vocal cord, depending upon the extent, and it would exclude the thyroid cartilage and the air cavity. And usually for T1 glottic cancers, there is no CTVP2. So this is how it would be. You include the tumor, you include the paraglottic space in its continuity, and then, but you do not include structures like the thyroid cartilage. And this is the 5 millimeter margins, which is the CTVP1, and this is the CTVP2, again, which can be cropped from the air and cartilage. Now for T2 glottic cancers, you need to include the paraglottic space, the anterior commissure, the vocal process, cranial part of the subglottic and caudal part of the supraglottis, and includes the thyroid cartilage but excludes the cricoid cartilage and the air cavity. So this is how it looks. Okay. Now for T3 glottic cancers, you need to understand. So essentially what you need to remember when you're reading this paper and when you're looking at disease and then scans, you need to include the gross tumor that you've seen and evaluated. In addition to that, you need to include areas that may harbor microscopic disease or into which there could be submucosal or direct extension of the disease, but which is not apparent now. Okay, so this is what you need to remember. And this is for T4 glottic cancer, but you need not go beyond the strap muscles, vertebral body, except when there is involvement or extension macroscopically into these structures. So this is what you need to know. Okay. Now coming to supraglottis, similar things I'm sure Jyoti Roop will be alluding to when he's talking about conformal radiotherapy, because this is the basis of doing conformal radiotherapy for the various head and neck sites. Again, similarly, you have the CTVP1, you have the CTVP2, and this is what it would look like depending upon the local extent as well as how you grow the 5 millimeter margins. Remember always to edit it off the air cavity as well as the uninvolved, or rather the natural barriers that offer effective barrier to spread of disease. Now for supraglottic cancers, again, don't go outside the thyroid if it is not involved. Okay, don't involve the strap muscles if not involved. Things like this you need to keep in mind. Same thing for supraglottic disease, which is of an advanced stage. Okay. Now coming to subglottic cancers, P1 isotropic margin, P2 margin of 10 millimeter in all direction, but in the subglottis you will include the cricoid cartilage but exclude the thyroid cartilage and air cavity. For subglottic disease, which is T2, again includes the cricoid cartilage, glottic larynx, tracheal mucosa, inferior part of the thyroid cartilage. Now for supraglottic and subglottic disease, you need to know that there is a finite incidence or chance of submucosal involvement, and you may have to give craniocaudally extra margins. Now this is the volume described for T3 and T4 subglottic cancers. The reason there are no pictures is essentially because subglottic cancers are very far and rare, and you really don't come across too often. And when the patient presents, the commonest sign of presentation is respiratory discomfort, and patients may end up having a tracheostomy and undergoing a laryngectomy. Now, of course, the guidelines paper also tells you how they have come to these margins of 5+5. And I would request all of you to go through that because it gives you an idea. Of course, it talks about tongue cancer in 2 of the papers, but talks about laryngeal and hypopharyngeal cancers based upon target volume delineation using different modalities. And of course, it also talks about microscopic extension. So you should go through these papers individually too. Okay, I won't go into this in the interest of time. Now coming to nodal delineation, again, I think most of you would be familiar with it, but no harm going through it again. And I would suggest to all first timers that they should actually sit with They should actually sit with the nodal guidelines and the contour that they are going to be doing together, because that actually makes it very easy, as well as the contour, the way to contour the various structures that are there becomes very clear and stays imprinted on your mind. So these are the various guidelines that are available. And of course, the one by Julian Biao, again from Vincent Gregoire's group, tells you what level of lymph node for what target. So now this paper from Vincent Gregoire again talks about the distribution of metastatic lymph node per levels depending upon the cancer, that is the subsite of the cancer. And this is for within the glottic, within the larynx itself. And from this paper again, it talks about what to do in the various nodal stages of the cancer. And this is the same, this is an excerpt from, which is an actually a more recent publication from Julian Biao. In addition to what is written in the table, I would also request you all to pay attention to the subscript, because it actually tells you about level 2B could be omitted if no cervical lymph node levels on the same side. 1B should be included in case of anterior involvement of level 2. Otherwise, you don't need to include it. Level 4B should be included in case of involvement of level 4A. Otherwise, again, you don't need to go so laterally into the neck. Level 7B should be included in case of bulky involvement of the upper level 2. So I hope all of you know what is level 7, 8, 9, and 10. Now coming to dose prescription in the definitive setting for early glottic cancers, T1, T2, we use hypofractionated schedules, typically 2.5 gray per fraction, or even more hypofractionated, like 55 gray in 16 fractions. In others with more advanced disease, supraglottic cancers, subglottic cancers, we use schedules that are equivalent to 70 gray in 35 fractions over 7 weeks, doing optimal volume reductions. In the adjuvant setting, we typically use a dose equivalent of 60 gray in 30 fractions to the area that was involved, and elective volumes receive a dose equivalent to 50 gray in 25 fractions. Now, role of hypofractionation, especially in glottic larynx. I'm showing you 3 papers here because these are 3 seminal papers in this particular area. The first one is the only randomized trial which has actually examined 2 fractionation schedules in the treatment of early glottic cancer, and the other 2 papers are from our institute, and I'll go through it soon. So role of hypofraction, this is the first paper published by Dr. Dinshaw. Trained in the UK, she actually used this regime most often, that is 50 gray in 15 fractions over 3 weeks. We also use 60 to 62.5 gray in 24 to 25 fractions, or used 55 gray to 60 gray in 25 to 30 fractions. These were the various schedules that we had used. Treated 676 patients. The primary endpoint was to look at local control. What we found was that all 3 regimes actually resulted in equivalent outcomes, but the incidence of laryngeal edema was significantly higher in larger field sizes where the volumes of radiotherapy were much larger, but it was not related to the fractionation schedule per se, and there was no difference in complication rates observed in radiation regimes. Now, this study by Yamazaki actually examines 2 radiotherapy schedules. One was 2.25 and the other was the conventional 200 centigrade. Again, no difference in the outcomes, but perhaps a superior local control for the shorter OTT without any adverse reactions. And there was no significant difference in terms of the acute or chronic reactions. And this is, of course, our later 26-year outcomes on the same group that I described earlier. What we saw very clearly was that one was a dose per fraction that is higher. the volume of radiotherapy being higher, these were actually determinants of outcome. But at the same time, we also noticed that actually telecobalt therapy for early glottic cancer is a safer alternative to treatment with 6 MV photons, and late toxicity and local control were acceptable so long as field sizes smaller than 36 centimeter cube was used. Now, pre-treatment audit. Now, I've patient, I've planned for radiotherapy. What all do I have to do? I have to counsel the patient about the treatment plan, the intended duration of treatment, the expected side effects and benefits. Counsel the patients about nutrition, oral hygiene, pre-RT dental prophylaxis, skin care, and of course, speech swallowing therapy, very important. Coming to the simulation process, most of us tend to use a 4 clamps or a 5 clamps thermoplastic device. Patients are usually positioned in the supine position. We use 3 lasers for alignment. The neck is usually in the neutral position, but for certain techniques for early glottic cancer, like the 2 anterior obliques, you may need hyperextension at the neck. Use of shoulder traction to move the shoulders out of the radiation fields. We do mark gross nodes by wires. A flow clamp thermoplastic mold is used. Proper measures for patients with Rayleigh tube and tracheostomy take care of this. And of course, the patient is aligned with the lasers, and then the thermoplastic mold is again made in the right position, and these laser lines may be marked on the ORFID so that they can be used for day-to-day alignment. Now, coming to what we do take X-rays, but you need to know a few of the bony landmarks on the X-ray. So here is the base skull, the mastoid. You have the C1 vertebrae, the C2, the largest and the most prominent vertebra in the cervical vertebrae, the epiglottis, hyoid bone, the mentum, the thyroid cartilage. These are actually enough landmarks when you're planning a larynx. Now, coming to the standard field borders. Now, T1, T2 glottic cancers, we typically use small fields, and usually they are bilateral parallel opposed fields. Typically, a field size of 5 by 5, 6 by 6 has been described. We would actually try to use a field that's smaller, provided it encompasses the disease adequately. The field size may be slightly larger for T2 disease, but please be very careful that T2 has to be appropriately examined, staged using good imaging. So the field boundaries for early glottic cancer, superior boundary would be at the hyoid bone, inferiorly at the inferior border of the cricoid cartilage or the C6 vertebral body. Anteriorly, it usually grazes the skin or a flash in air. Posteriorly, at the junction of the anterior third and the posterior 2/3 of the vertebral body. This is typically a field for early glottic cancer, and this is the kind of distribution that you would get. Now, in obese patients with a short neck, we use anterior oblique portals to spare the skin laterally as well as get adequate coverage of the target volume. But here we do always take a CT cut. Patient is positioned with hyperextension at the neck, and ORFID is a thermoplastic mold is prepared. We use a bolus to be able to actually compensate for the missing tissue at this level, as well as build up the dose at the level of the anterior commissure. Use appropriate wedges at this level. Even though this is a conventional technique, we do use the CT for adequate and appropriate planning. And this is the kind of distribution that you get, and the wedges and the bolus that you would need to use. Now, coming to T1, T2 supraglottic larynx, this is classically what has been described in the textbooks. So you have the superior border along the inferior border of the mandible, anteriorly again in air. Posteriorly, it is beyond the spinous process of the C2. At phase 2, you come off the cord, and inferiorly at the level of the head of the clavicle. Okay, this is for supraglottic cancer, and this is the off-chord field, and this is what I would show you. This is again what we would do. You use a larger field, phase 1, phase 2, you come off-chord, and then depending upon the superior and inferior extent of the disease, you may also do a further phase 3, so that you keep reducing the volumes that receive the highest dose possible. Now, in subglottic larynx, typically the echilion of lymph nodes beside the bilateral level and 2 and 3 that may be at risk. The other level that is at risk is the level 6. And hence it is also important for us to cover the superior mediastinum. So a typical, in the conventional setting, you would end up using a T-shaped field in the phase 1 and then come off-chord in the phase 2. And in this, you could either use 2 anterior obliques or you could use bilateral off-chord fields. The bilateral off-chord fields are usually not sufficient for adequate disease coverage inferiorly, so it has to be titrated according to the lower extent of the disease. Now, use of beam modifying devices. What are the various beam modifying devices that we use during laryngeal cancer planning? Wedge. A wedge is necessary for early glottic cancer for appropriate posterior coverage as well as homogeneous dose distribution. A wax bolus is used because you need to actually pull the dose up, especially in the area of the anterior commissure. And if you are using 2DRT and telecobalt and want to deliver 66 to 70 gray to the neck, it is best to use tissue compensators to be able to deliver these doses appropriately with acceptable morbidity. So this is the kind of planning that you would do using wedges. You can see the effect of the wedge in trying to cover more posteriorly and well. This is the kind of distribution that you would get with and without a wedge filter. Now, the advantage of using the bolus, if you did not use a bolus, you would not get adequate coverage in the level of the anterior commissure as it is just below the skin. Now, the other thing that we use routinely and make it for each individual patient is tissue compensators, because we need to deliver appropriate doses, high doses, and at the same time have acceptable morbidity, and that can be done only by the appropriate use of tissue compensators so that you do not overdose or underdose the neck and the larynx. So this is how it is fabricated for each individual patient. Now, the 3-field technique, where do we use the 3-field technique? We use it when there is level 4 lymphadenopathy, the disease extent beyond the subglottic region, or a tracheostomy is present. What are the fields? We usually use bilateral parallel opposed and a low neck field. The dose that we give is typically 46 gray or a 40 gray equivalent bilateral off-chord. Then you would come down to 50 gray to the low anterior neck. If there is gross disease, you would boost that area. So this is the typical portal arrangement. Larynx block is used and lung blocks. Now, if you look at your textbook, you will typically have blocks like this. So you have a block that is used at this level, a block that is used at this level, and another block in the larynx. So you have lateral blocks, you've got anterior blocks. What is important is the matching of the fields at the area of overlap. So this is something that you have to keep in mind. And how do you do that? One is if you use straight fields, no collimation. Next is you actually match or align to the divergence. And the third method is, of course, to use monoisocentric techniques. Now, what are the planning points that you need to keep in mind when you have a tracheostomy in situ? Essentially, you need to cover the tracheostomy adequately, especially for advanced disease. If the tracheostomy was done through in the presence of disease before surgery and in the presence of positive margins. So you need to cover it adequately. So typically we do that using APPA fields. We go at least 1.5 to 2 centimeter below the inferior extent of the tracheostoma. And then when you are coming off chord, you either give 2 anterior obliques or use an anterior beam that is weighted, or use electrons essentially to kind of boost the dose to the tracheostoma. Now, these are the kind of constraints that we aim for. Of course, this is more applicable to the conformal setting, but you have to remember that we usually do not exceed the tolerance of the spinal cord. So an off-cord field is done at 46 gray in 23 fractions, brainstem dose not beyond 54 gray. These are things that we usually have learned right from the beginning and we adhere to in the conventional setting. Now, no talk on radiotherapy is complete without alluding to the toxicity. So if you look at this paper from Michel Macte, what you need to remember from all the various RTOG series, as your combined modality treatment becomes more aggressive, your incidence of toxicity also increases, and that is essentially the grade of the toxicity that worsens. Most patients would end up requiring some or the other form of painkillers. About 16% would require hospitalization. NG tube feeding may be required in almost about 19 to 20% patients. Several patients would lose significant weight. And of course, dysphagia would be a consequence of the mucositis that you come across. On-RT review is absolutely mandatory as much as the treatment, at least once a week, to reiterate instructions on clothing, skincare, orodental hygiene, and check compliance. Nutrition, weight, hydration, attention to speech swallowing therapy, review more frequently if necessary, especially if you have reactions that are worse than anticipated, if there is significant weight loss, and in certain other special situations where you're using a different kind of concurrent chemotherapy schedule, etc. Now, post-organ preservation treatment evaluation, clinical evaluation is important, weight, speech, and swallowing therapy, endoscopic evaluation, and CT scan 6 to 8 weeks after treatment. If you want to do a PET CT scan, there is no obvious progression, there is a favorable response, do it after 12 weeks of therapy. Thyroid function tests need to be done at 6 months. And of course, re-emphasize tobacco and alcohol cessation. In case of residual tumor, the patient can be evaluated for salvage surgery with or without neck dissection. Thank you very much, and I'd be happy to take any questions if there are.
Thank you, madam. So I would kind of hand over the mic to Dr. Vidisha Ghosh-Noskar, madam, for continuing the session. Madam, please.
Thank you. I think Dr. Manish Kumar Chaturvedi, he has a question. Please go ahead. Please, Manish.
Madam, may I kindly interrupt, please? Actually, a communication was made that after both the talks on radiotherapy planning, we will proceed with the questions.
Okay. Thank you, Dr. Loskar, for the nice representation of the contouring guidelines. Next speaker is Dr. Jyotirup Goswami. He is in Saroj Gupta Cancer Research Center. He will talk about overview of conformal planning in thyroid and laryngeal malignancy. Dr. Jyotirup, please.
Thank you, Vidisha Di. I hope I'm audible.
Yes. You're very much audible.
Right. So thank you to Abhishek and the team for having me on this segment. I know the team has been doing some really great work, Ostha, Anupam, Monideepa, and Dipanjan. And I have to say that these sessions are mostly aimed at the PG trainees. So I've tried to keep my talk on that level, as Madam has also done for her talk. So she's actually made things very easy for me because she's actually gone through quite a lot of what I'm going to present. So bear with me. So this is talk on conformal radiotherapy for larynx and thyroid. And obviously, you could ask, why do we need conformal radiotherapy? And as Madam has just said, it's basically to reduce normal tissue complications, which potentially allows us to deliver high or even higher doses without the problem of late toxicities. Just for the PGs in the audience, some of whom may not have seen conformal radiotherapy, the workflow is quite standardized. So you would do an immobilization, a simulation scan, you would do the contouring, then the planning, and then you would treat the patient potentially after doing a quality assurance of the plan. So moving on to larynx planning, I think Madam has already covered the anatomy, and we've also got our radiologist slightly ahead in the program to tell you more about it. So I'm not going into that. But this slide is very important. Madam has shown it as well. I actually pinched it from one of her presentations. This originally is from Cliff Chow. So what it tells you is that glottic cancers are not known to throw off lymph node metastases if they are clinically, if there are no clinical nodes palpable. But supraglottic node cancers are much more prone to nodal metastases, and mainly to levels 2 and 3. Contralateral nodal metastases can happen in a fairly large number of cases for supraglottic cancers. Why I'm going through this again is because what we treat is obviously determined by why we need to treat it. And this is, of course, from Perez. And it tells you that there's a very high incidence of nodal metastases from the supraglottic larynx to level 2 on the ipsilateral side and to level 3 as well. Even level 4 has a higher than 20% chance of nodal metastases. On the contralateral neck, it's obviously less common, but it's still high enough for us to routinely want to treat levels 2 and 3 on both sides. So as Madam just said, we would do a simulation with the patient immobilized with the thermoplastic mold. Normally we'd use a neutral neck because that's comfortable and reproducible, but for short necks like mine, it would be extended. You would do a planning CT scan going from the vertex to the mid chest using 3 millimeter slices and using contrast unless contraindicated. These are the OARs that are important for conformal radiotherapy planning. Obviously, we know about the spinal cord and the brainstem, we know about the parotid glands, but there are a lot of other structures which are not really a priority to begin with, but we do want to ensure that we're not dumping extra dose on these structures involuntarily. So mandible, TM joint, important in terms of events like osteonecrosis, trismus, oral cavity. Obviously, the patient's quality of life is very important, and we don't really need to treat the oral cavity for a laryngeal cancer, so we need to try and minimize the dose there. Thyroid gland, yes, post-radiotherapy hypothyroidism is important. We try and minimize the dose if we can. I don't think constrictors are routinely spared for laryngeal cancers as far as we do in our practice. And of course, you've got cochlea and brachial plexus as well. These are slides from the RTOG normal structure anatomical atlas. And I think we've all of us been through these structures. You've got the CT on the top and the MRI on the bottom. Just good to look through them every so often so that you don't forget where each structure is, especially the smaller little ones like the cochlea and so on, and the constrictors as well. So it's just good to run through them. And moving on to planning proper. So we've just discussed about T1, T2, N0 glottic cancers. And we know that these aren't cancers which throw off nodal metastases. So we would not need to treat any lymph nodes prophylactically. So the CTV is basically the larynx, and the BTV is a margin of 5 to 7 millimeters. It's good to use simple bilateral fields with MLC shapes. And the important thing to know is that because this is a superficial structure, so we can't be too cute with our planning, especially using IMRT, etc., because we need to ensure that we're covering what we intend to cover. So ma'am has just spoken about the beam modifying devices like the wedges to reduce the beam inhomogeneity from anterior to posterior, and also the importance of the bolus. And I've got a slide on that as well. So the anterior commissure, because it's very, very superficial, may not be covered well if we don't use a bolus. And this is probably more important for a LINAC, for a 6MV beam, than even for a cobalt. So I think, it's important that while we all do our fancy IMRTs, etc., that we do remember to treat glottic cancers with a bolus. So that's why we need to treat it with a bolus. So you see in the slide on the left, you've got quite a big dip in coverage of the PTV, which is compensated by using the bolus on the slide on the right side. And I know that there was a question on the bolus, so I hope that answers your question. Moving on to, if you like, the more interesting part of presentation, where we're treating supraglottic larynx or node-positive glottic cancers. Again, ma'am has spoken about the two target, the 5+5 concept, which actually wasn't there when we were first training in conformal radiotherapy. So we would tend to have just the one CTV primary, which was usually the whole larynx. And it's taken a bit of adaptation to move from there to this concept of a high risk and an intermediate risk target. And it makes sense in terms of pathology, but it just means that the targets are going to look a bit different from what they did in the past, because they might just be slightly more asymmetric, because we don't need to include the whole larynx. We would include the GTV with a margin. And as ma'am has said, it's very important to remember that we don't include the thyroid cartilages and the air cavity in these CTVs, at least not in the CTV high risk, although the CTV intermediate risk can actually go beyond, as we've been seeing in some of these images. So you see in this one, for example, the intermediate risk CTV does go slightly beyond the cartilages, but not beyond the strap muscles. And we've seen these images in the previous presentation. I think it's good to look through these guidelines. They're so good. And the images are so representative. I think, it's much better than going through a number of different cases, because each one of these is actually a proper case on its own. And that's an advanced T4 larynx, when and if we need to treat it. And the lymph nodes. Obviously, we've been reading just now about why we need to treat those lymph nodes. And we do need to treat the involved nodes, obviously, and also the uninvolved nodes based on the risk of lymph node spread. So we've seen one of these slides. There we go. So even for a node negative patient, we would still want to prophylactically treat at least levels 2 and 3, and preferably 4A as well. If there is transglottic or subglottic extension, which is very important, especially for conformal planning, because we just tend to draw our GTVs and not really take into account the whole importance of subglottic spread. So it's very important to cover the level 6 in such cases. And obviously, if you've got lymph nodes involved, you need to then also irradiate some adjacent nodes. So as we just heard, if you've got level 2 bulging out anteriorly, you would treat the level 1B, and also the base of skull nodes and the level 5 nodes. Now, the lymph node volumes would be either 2 or 3 volumes, depending on whether you use 2 or 3 dose levels. So if there are gross lymph nodes involved, those would be treated to a radical dose. Regarding the elective nodes, there are some centers which would use an intermediate level of 60 and a lower level of 50 equivalent, and that's been the practice at TMH, and I think that's been the practice for most of us.
Jyotirup, did you just finish your presentation?
No, madam, I think there was a technical snag. He'll be back soon. I'll just try to connect.
Okay.
Meanwhile, Onnoy, can I ask you to take a couple of questions till Dr. Goswami rejoins?
I think that will save our time. It's better to do that.
Sorry, I'm back actually. My computer
Okay.
decided to restart for no particular reason. So I'm sorry about that. I'll just get back to the presentation.
Dr. Goswami, you can start.
Yeah. So I think my slides are visible again. I'm sorry about that. It's always nice when Windows decides to update itself. Right. So yeah, I was talking about using 2 versus 3 dose levels. So people who use 2 dose levels would have a 70 and a 50 gray equivalent, but quite often we would use those 3 levels with an intermediate of 60 gray equivalent. And the level 6, I know we've got radiology after this, but it's important to just remember that the level 6, which we don't normally treat for other structures, is an integral part of treatment for laryngeal cancers. So it extends from the manubrium sterni caudally to the lower border of the body, the thyroid cartilage. And that's a very important space to cover. The other question that someone asked me quite recently was about covering the stoma and how important that is when you've got a radical radiotherapy going, but you've had a tracheostomy done previously. So if it was an emergency tracheostomy, you would definitely want to cover it. And if there was suspicion of subglottic spread, you would again want to cover it. And possibly if it was transglottic as well. So I think that that's important to know, even if it doesn't appear involved, that you would need to cover it with a lower dose. Now for adjuvant radiotherapy, we would treat the tumor bed and the nodes. Depending on whether the nodes are involved or not, we would treat the nodes to 50 gray or 60 gray, and obviously the post-op dose is 60 gray. And conformal radiotherapy techniques, well, we all know what they are. We would routinely today use IMRT and VMAT, but my previous center, as we were starting up in Narana, we were using a complex field-in-field 3D CRT, which in fact was used in the trial at TMH comparing IMRT and 3D. And this is actually a very rewarding technique to use, which has quite good sparing of even the parotids if it's a laryngeal primary. Normally we'd use 5 to 7 fields and 6 MV photons. Beam spacing would be about 50 or 70 degrees. And we've seen the constraints, so nothing much to add to that. The parotid doses would, you try to keep it to 25 gray if it was both parotids to be spared, and 20 if you could spare only one, and spinal cord dose, as we all know, is 45 gray. It's important for the brainstem dose to be counted as well if we're treating base of skull nodes. And there are those soft constraint structures such as the oral cavity, the thyroid gland, which are not crucial, but which are important to not have hotspots coming up in them. And ma'am has just talked about the doses we would use. So for the little glottic cancers, it would be 62.5 in 25 or 55 in 20. I've used both, and I like both of these. For the other cases where we're treating lymph nodes, you can use 2 gray per fraction or 2.2 gray per fraction. And again, you could use either the 2 or the 3 dose levels. For adjuvant, 60 grays, if in case the margins are negative, and for positive margins, and even for extranodal extension in the lymph nodes, you would go for 66 gray. So that's about larynx, and I've just got a few slides in the thyroid, so I'll finish off with those. So as ma'am was saying, that it's not just about anaplastic. We do have a role to play in differentiated thyroid cancers as well. The role is a little bit vague, and I've always had a question about the role myself. So broadly speaking, we know that it's useful for metastatic settings. It's definitely useful for unresectable local regional disease. But what about adjuvant treatments? So what are the indications? So obviously extrathyroid extension or nodal disease are indications we would look at for giving adjuvant radiotherapy, but not all groups accept this. And especially for younger patients who could be cured just with the radioiodine, they haven't always recommended external beam radiotherapy. So there's that. The other question is, what comes first? Is it external beam or radioiodine? For other head and neck cancers, we would normally try and start the radiotherapy in 4 to 6 weeks' time. And I think that way, external beam first would make sense, because we know that radioiodine can be delayed till up to 3 months to be as effective. But there is also the argument that external beam radiotherapy can sort of stun the thyroid cells and sort of prevent optimal radioiodine uptake. These are the guidelines which are mentioned, just pulled from Perez, and you can see that not all the groups actually have consensus on adjuvant treatment particularly. And finishing off with the other 2 thyroid cancers, we hardly see medullary thyroid cancers, but if you do have a patient with inoperable or R2 resection, you would try and treat that with radiotherapy. Anaplastic thyroid cancers, probably some of the most hopeless clinical scenarios we would see in routine practice, usually would be unresectable. I've never had a patient to treat with radical chemoradiation, but it can be done if you have a patient with a good performance status. And so it's usually palliative radiotherapy. So the doses are quite similar to what we use for other head and neck cancers. And the volumes, again, broadly divided into the low and the high risk volumes. I'm just going to rush through these because I know we're running short of time. So you can see the slides which will be shared. And before I finish, I would like to acknowledge the sources. We've all heard about the excellent publications from Vansa Gregoire's group, but I would particularly like to thank Professor Shorbani Loshkar herself, because she's been a wonderful teacher and her presentations have been absolutely essential reading for me in my residency and even today. Thank you so much.
Thank you, Jyotiru, for your elaborate teaching. I think first year and everybody of us will be benefited by your and Dr. Loshkar's speech. And next in line, Dr. Kaustubh Mojumdar and Dr. Shonak Pal. They will tell us about radiology, anatomy, radiology of anatomy for larynx and thyroid. I'll invite them.
Madam,
Please.
Thank you, madam.
Uh,
Good evening, everybody.
evening.
Thank you, AROI group, for having me consistently on this platform. I don't know if it is of any use or not, but still I'm enjoying this interaction with all of you.
Thank you, Shona, for
And
joining with us. So this is a really pleasure to have you in for the radiology class. So we'll not delay again. So we'll start with larynx first. Are you ready, Shona? Hello? Hello?
Yes, Dr. Kaustubh, I'm ready.
Am I audible?
Yes, you are audible. I
Okay,
got
okay.
muted. Sorry. Please tell me.
Okay.
Shall we go ahead with the cases?
We'll start with the So we'll start with the supraglottic larynx. And could you please show us the total larynx in the coronal and axial section, the caudal part and the cranial part, along with
Yes,
two
yes.
side?
One second. Yeah. So I will take a few cases with malignancies in the larynx so that it becomes a bit easy for us to understand what part of the anatomy we are talking about. So this is on the axial section, this is the level of the oropharynx. As we go inferiorly, we have the epiglottis, which is fused with the hyoid by the hyoepiglottic ligament. Okay. And anything below this,
Dr.
am I?
Shonak and Dr. Kaustubh, this is Dr. Abhishek. So
Hi,
can I
sir.
just interrupt you? I'm extremely sorry, but because this will be a very interesting session, we do not want to delay having the questions that are already pending for Dr. Laskar ma'am and Dr. Goswami. If we can quickly run through the questions, because then you will not have any constraint for time. You can continue till that is required, and that was one of the aims that we actually deferred the radiological anatomy later so that you can continue without any constraint of time. So if I may please ask.
Yes, sir. I think that will be
The questions, some of them have already
nice.
been answered, but while you are both on, so please hold on for just a couple of minutes so that the questions are answered, and then we can do the radiological anatomy uninterrupted. Thank you so much.
So the first question is from Dr. Abhay, and he asked about when should we consider altered fractionation RT in case of supraglottic larynx?
Do you want me to answer that question?
Yeah, madam.
Okay. So as I showed you, we consider altered fractionation. I'm talking about head and neck in general and larynx in particular. So there are two kinds of altered fractionation, especially when you talk about laryngeal cancers. For early glottic cancers, as I've already told you, you have hypofractionated radiotherapy. That means you have a higher dose per fraction, total number of fractions per week remaining the same, the total number of fractions in the entire package going down, the total dose also somewhat lower, and finishing within an early period of time, which means you're giving 55 in 15 or 55 in 16 55 gray in 16 fractions, or a 62.5 in 25 fractions. So that is hypofractionation in the curative setting in early glottic cancer, T1, T2, N0, M0. In the advanced forms of laryngeal cancers, when patients are not suitable for chemotherapy, or you want to replace chemotherapy for whatever reason, you can do altered fractionation radiotherapy. And this altered fractionation radiotherapy, the best outcomes are with hyperfractionated radiotherapy. You have the URTC study and you have the University of Florida series, where the total dose delivered is higher. The dose per fraction is 1.2 to 1.5 gray per fraction, 2 fractions per day, giving almost about 46 fractions and delivering a dose closer to 79 to 81.6 gray, depending on the regime that you are using. So that is hyperfractionation. There are schedules that have also used hyperfractionation with concurrent chemotherapy, but those are highly toxic schedules, and perhaps in this patient where you want to use altered fractionation, they may not be suitable candidates. So if you want to replace chemotherapy for a patient who is not suitable for chemotherapy, you can do hyperfractionation or accelerated radiotherapy without a reduction in the total dose. I hope I've answered your question.
Another question regarding this altered fractionation, the question has been repeated from two different persons. The role of hyperfractionation in early glottic cancer, what is the logic behind it?
So tell me, you should be telling me the logic. You are all PG trainees. What do you exploit when you are doing hypofractionation in early vocal cord cancer? You are exploiting two essential features. One is the potential doubling time is low, so which means that its expression of late effects will be lower. The second thing is that the glottis is a relatively lymphatic sparse area. That means the propensity for lymph node involvement is very, very low, less than 1% in T1 tumors. And that is why you can exploit these two features to actually do hypofractionated radiotherapy with a higher dose per fraction, delivering biologically equivalent doses to 70 gray in 35 fractions, using small portals, high dose per fractionation, and doing no elective radiation. Is that clear?
And the third question directly to you from Dr. Kannan. His question is the use of gel bolus in CA vocal cord with anterior commissure involvement in IMRT planning. Is it necessary?
So now see here, what I would like to tell you is that IMRT is all good, but if you have a lesion that is coming to the anterior 1/3 of the cord or involving the anterior commissure and you're using 6 MV photons for treatment, you have to be very careful. And I think both me and Jyotiroop alluded to this concept that when you're using 6 MV photons, you have to be very conscious about the skin sparing effect, and you may require a bolus in the anterior half of both fields, or if you're using an arc like in VMAT, or if you're using two anterior oblique fields. So with 6 MV, you may require to use a bolus. Typically what we used to do is when we're doing that, we actually see the plan without a bolus, then use a virtual bolus. And if the plan is better with the virtual bolus, then we add the real bolus for treatment of the patient. So it is important for you to do an actual evaluation of the actual plans across all these slices, see the distribution, especially in the region of the of the anterior commissure just beneath the skin, and then decide on using boluses. But yes, when we used to do two anterior obliques or bilateral fields on 6 MV, definitely we used to use a bolus to avoid skin sparing and also underdose at the anterior commissure level. Is that clear?
Madam, we have another two questions from Dr. Abhay. One is, could we consider middle of thyroid notch as superior border for early clotic cancer?
Yes.
And the next one is, he wants to know how do we reduce the dose to lung apex in case of low anterior cervical field?
So for the low anterior cervical field, we usually prescribe at 3 centimeters depth or surface dose, depending on whether you have an actual node that is involved or you're treating microscopic disease. So if you're using a 3 centimeter depth prescription, then of course your dose to the underlying lung will be higher. But if you have to treat a grossly involved node, there is no doing away with it. So what I would suggest and what we typically do is use lung blocks beyond the margins of the elective field. So if you saw the pictures, you will remember that below the clavicle, we just give about a centimeter space and then put triangular blocks to spare the apex of the lung.
Hello.
Hello, madam, may I move on to the next question?
Yes, please.
Yeah. Madam, so next question, Dr. Abhay and Dr. Devanjan Kundu probably both have the same question. Is what would be the best treatment modality after recurrence of supraglottic carcinoma? Dr. Devanjan Kundu has specifically asked for recurrent setting in a treated patient of glottic larynx T1A N0M0.
See, when you have a recurrence which is documented on examination followed by a biopsy and an imaging evaluation, you will then have to consider the modality that has not been used already. So most often for laryngeal cancers, after radiotherapy alone or concurrent chemoradiotherapy, we would do an evaluation workup, restaging workup, depending upon the performance status of the patient, the extent of disease on the imaging, if the patient's disease is resectable, we would go ahead and do surgery. Now, in early glottic cancers, the concern often with offering radiotherapy upfront is whether this patient can then still be considered for a conservative laryngectomy. It would, if the patient was a candidate to begin with, and even now, if the extent of the disease is such that a conservative laryngectomy can be offered, has adequate pulmonary functions, you may still consider the same for this patient, but of course, it will be a function of the extent of disease and the functional status of the patient. For more advanced laryngeal cancers, again, if the patient is resectable, you would take recourse to a salvage laryngectomy. That would be the treatment for these patients.
Just to elaborate the question,
Anything
just to
else?
elaborate whether the recurrence, if the recurrence is after say 3 or 4, 5 years, so shall we still follow the same course, or will the patient be eligible for a re-irradiation in that setting?
No, you would still go for surgery. Please remember, after a recurrence, especially after radiotherapy, you would assess for surgery. Across all head and neck sites, the best treatment after recurrence is surgery followed by appropriate adjuvant therapy if available and if possible. Whether it is 3 to 5 years, whether it is 1 year, if the patient is resectable, patient will undergo surgery. Also, if you look at the papers and the literature, you will realize the larynx and the hypopharynx are not very good sites, are rather the worst sites for re-radiotherapy. So yes, even if it is 3 to 5 years, even if it is 1 year, and the patient is resectable, I would send the patient for a salvage laryngectomy rather than doing recurrent, what you call re-radiotherapy. Any other questions?
Madam, could you take somebody requested you?
Please speak up.
And the last question is
yeah, Madam, Dr. Devajyoti has requested you to kindly explain the anterior oblique portal and it's
You want the simulation process?
Yeah.
Yeah. Okay.
Yeah,
Now,
anterior oblique portal.
so this is a technique that we used to follow, and this is something that has been described typically in Jane Dobbs. So we used to use this for most of our patients when we used to do the hyperfractionated schedule of 55 in 15. But this is essentially a technique that has been described for people with short, stocky necks, where you don't have adequate length of the neck. So the patient is actually immobilized on a neck roll, which sees to it that the neck becomes extended so that the area of interest, that is from C2 to C6, becomes straight and is parallel to the couch. That's the first step. And you align the patient using the lasers. After that, you make the ORFIT also in that position, that is the thermoplastic mold also in that position. We know that these patients, if they're going to be treated on a 6 MV linear accelerator, will also require a bolus. So we used to typically then simulate. So after you've done the laser alignment, then you take the gantry anterior, check the alignment, then take it on the side of the involved cord, a lateral, dead lateral portal. Okay, to check your portals that you've achieved superior border at the level of the hyoid, inferior border at the level of the C6, posterior border at the junction of the anterior 1/3, posterior 2/3, anterior border in A. You've confirmed this, then take the beam, the gantry head 45 degree anteriorly, or if there is a lot of disease laterally, you may need to splay out your fields and do a 60 degree oblique. But otherwise, usually a 45 degree oblique would suffice. So you take the gantry then at 45 degree, confirm that your field is still off chord, it is adequate, mark this, same thing you do on the other side. And this treatment is usually delivered with the SAD technique, a typical depth that we would get would be around 3 to 3.5 centimeters depth, and a field of around 4 into 6 or 4 into 5 centimeters dimension. So that is how it is done. It is simple, but it is more complex and requires a lot of expertise in setting up and taking your portals adequately as compared to the bilateral portals. I don't know whether I'm clear, but that's how you would do. Here, what is different from your conventional portal or bilateral portals is essentially the positioning of the neck, which is now hyperextended, and how you take your fields, your portals. First, you take the dead lateral, then come to your 45-degree to mark the portals on the thermoplastic mold.
Okay.
Thank you, madam. Thank you. I would ask Vidisha madam to kindly proceed with the further proceedings.
I would love to actually stay on, but I'm sorry, I may have to excuse myself. Is that okay, Abhishek? Vidisha, is it okay if I excuse myself?
Yes.
Okay.
It's a very long time. Thank you very much.
Thank you.
Thank you very much. Okay.
Okay, bye. Good night.
Good night. Okay, Dr. Kostab and
Dr. Shonak, yes.
Shonak. Please,
Yes, ma'am, we are
please
here.
proceed. Okay.
So I think we were stuck at the question of defining the extent of the
Yeah,
larynx.
Larynx, yeah.
Yeah. So this is the epiglottis, and this is the free margin of the epiglottis. And when it fuses with the hyoid bone, just give me a second. Am I audible?
Yeah.
Yeah. Fuses with the hyoid bone. There it starts as a non-immobile portion of the epiglottis, and this is the level where the supraglottis starts. And as we go further down, we see the arytenoid cartilages, the paired cartilage on either side of the posterior margin of the cricoid cartilage. And as we go further down, we can see the thyroarytenoid muscles. Okay, these are the straight muscles with very minimal fat between the muscles and the thyroid cartilages. As we go further down, the division of glottis to subglottis radiologically is defined on the coronal plane. So just let me zoom it out a bit. And this is the level of the arytenoid cartilages. And as we come forward, this structure is the muscle, and as we can make out, this fuses here the level of the anterior commissure. Okay, this is the anterior commissure. So you can see a air gap between the superior margin of the thyroarytenoid muscle of the true cord, and there is another J-shaped structure here. So this is the false cord here, and this is the true cord. In between is the laryngeal ventricle. So anything above the superior margin of the thyroarytenoid muscle is the supraglottis, and how we define the extent of the glottis by an imaginary line through this, which is roughly 1 centimeter below. So 1 centimeter below, we draw another line, and along this line, this is the extent of the glottis radiologically. Okay, and below this 1 centimeter line, I'm holding my pointer at this point of the inferior line. Below this line, whatever is there, it is the level of the infraglottis. Okay, until it fuses to form the trachea. This is grossly the anatomical distribution of the parts of the larynx.
Okay.
And
So next we move to, I think you have already shown the supraglottic very thoroughly, the false chord and the idiopathic fold. Next we are going to in the glottis. In axial section, could you please show us the true chord, anterior, posterior, commissure, and the infraglottic space, if possible?
yes, sure. So we trace the true chord from the level of the arytenoids up to the anterior commissure. Whatever muscular structure here is the true chord. Okay. Next is the anterior portions of these true chords fuse at the level of the joint between the left and right lamina of the thyroid cartilage. This location is the location of the anterior commissure. And the posterior commissure is not so pointed structure. It is the level between the two thyroid arytenoid cartilages. The entire area is called the posterior commissure.
Okay. And you have already shown, I guess, the infraglottic space. Is there any specific thing of the infraglottic space?
Yes. I think you're asking me about this subglottic ring and okay. So what happens when we see the cricoid cartilage, when we already have crossed below this muscle, below the level of this muscle, there is no muscle any further. This is the cricoid ring. Okay. As we go inferiorly, it is a complete ring anteriorly. And as we go superiorly, it is an incomplete ring with the cartilage being higher at the posterior aspect, forming the incomplete ring posteriorly. The mucosa always hugs the cricoid cartilage. So if you have any soft tissue between the air and the cricoid cartilage, air within the lumen of the larynx and the cricoid cartilage, it is always a subglottic extension of the tumor. Okay, so at one go, if you see any structure, any soft tissue structure within the ring of the cricoid cartilage, except for the airway, it is a subglottic extension of the tumor. You don't even need to go back to your coronal to delineate how far it is going. Therefore, surgical purposes, as the anterior margin of the cricoid is way inferiorly complete than the posterior margin, which is complete way superiorly. So whenever there is a subglottic extension anteriorly, roughly up to 1 centimeter below the level of the anterior commissure or the true level of the true chord, it does not preclude surgery. Whereas if the extension is just within 5 millimeter from the posterior commissure up inferiorly, then it allows surgery. But have I been able to explain myself? So
yeah, absolutely fine. This is absolutely fine, Sona, from your side, the levels. Do you want to add anything here in the larynx?
yes, just
Yeah,
one more
sure.
thing, sir. So this is the level of the anterior commissure, and whenever we have anything within 1 centimeter from the inferior margin of the anterior commissure, we are not yet touching the cricoid cartilage. Okay, so a surgical excision along this level is possible. However, the cricoid cartilage goes up to here, this level, and excision will be difficult in cases where there is minimal extension of the tumor along the posterior margin of the larynx into the subglottic segment. Next question, Dr.
So,
Would you give me a minute more to explain
Sure.
myself on this sagittal anatomy?
Oh, sure, go ahead.
I am probably stretching it too much.
Okay.
So this is the hyoid bone. This is the epiglottis. This part of the epiglottis is the free or mobile segment of the epiglottis. And from here till the level of the anterior commissure, it is the fixed portion of the epiglottis. And this structure that we had discussed in the prior class, I believe, is the floor of the vallecula, which is formed by the hyoepiglottic ligament. And this is the fat in the anterior to the epiglottis. This is the pre-epiglottic fat. In this particular patient, we have a tumor which predominantly involves the immobile or the fixed segment of the epiglottis, which extends up to the anterior commissure. Okay, so we'll take your questions, Dr. Costa.
Okay, so in continuation with it, could you show us the parts of the hyoid bone and the thyroid cartilage? Is
Okay.
it feasible? Yeah.
So hyoid bone is the first bone below the level of the mandible that we see. So this structure is the hyoid bone, the body. And as we go posteriorly and superiorly, this is the greater horn or greater cornu of the hyoid bone, the most posterior and superior part of the hyoid bone. The lesser cornu is not always visualized properly. This bump in the cartilage bone is the lesser cornu of the bone. And I think we had discussed the middle constrictors insert on the hyoid bone. So when you have this posterior margin of the oropharynx, you can see this constrictor which is going up to the level of the hyoid bone, and this is the middle constrictor. Next question, Dr. Costa.
Thyroid cartilage.
Thyroid cartilage. Yes, yes. So unlike the hyoid bone, which is very obviously seen because of its ossification, the thyroid cartilage is irregularly ossified in most cases, and this part of the thyroid cartilage is ossified, whereas as we go higher up, the part of the thyroid lamina are non-ossified. So the one thing that I would like to impress upon you all is where to call it. It's an extra laryngeal extension. Please always remember that if your tumor goes across the level of the thyroid cartilage into the outside, on the outer surface of the thyroid cartilage, it is an extralaryngeal extension. Unless until you see that, you cannot be very sure on a CT scan because of irregular ossification of the thyroid cartilage. If you need to know whether thyroid cartilage is involved and you don't have a tumor on the outer side of the thyroid cartilage, please get an MRI with a contrast. Okay.
So is there anything horn of the thyroid cartilage? Could you want to show us?
Yes, sir. As we go inferiorly, this is a superior extent of the thyroid cartilage, as you're calling the horn, and anteriorly, the lamina fuse at the midline, and this is the inferior margin of the posterior aspect of the thyroid cartilage. At this level, you usually are finished off with the level of the cricoids, and just inferior to this, your trachea starts. Okay.
Okay. So we are moving to another important thing during any radiological anatomy or contouring. It is required, that is the parts of the vertebral body, especially in the cervical vertebra, as we are dealing with head neck now. So could you please show us the parts of the vertebral body?
Okay, I will take you through a few of them. This anatomical structure, I think everybody is very familiar with. Okay, there is a small dot and there is a ring. This is the odontoid process, and this is the C1 vertebra. I think you can appreciate there is some amount of vertebral erosion in this particular patient, and on the right side we can see the vertebral foramen. On the left side, there is soft tissue that has engulfed the vertebral foramen. As we go down, this is the C2 vertebra. Again, there is some amount of erosion in this. There is a soft tissue mass, and this is the base of the C2. However, when we go to other vertebrae, except for the C1 and C2, they all look alike. So please do not try to check the level of the cervical or any, for that matter, any vertebra on an axial. You have always to go back to the sagittal and count it from top down, whichever modality of imaging you are using. So coming to the basic vertebral anatomy, this is the part of the body. This is the transverse process, and these two holes in between are the foramen transversorium through which the vertebral arteries go. These are the pedicles, these are the laminar processes, and this part is the spinous process. This heart-shaped structure in between is the cervical vertebral canal through which the cervical cord goes, and we can see there is some spaces between the articular facets on either side and the body. This is the level of the exit foramina, neural foramina, through which the consecutive neural cervical exiting nerve roots emanate.
Okay, okay. Thank you, Shona. So now moving to the in relation to vertebral body, so we'll move to the brachial plexus. So for contouring of the brachial plexus, we need to know some of the structures. One of the important structure is the scalene muscle. Could you please show us once again, though you have shown us in the last segment of
Yes,
our
doctor.
class?
Just a minute. Let me get back to the abdominal window. So we check for the scalene muscle at the level of the root of the neck. So this is the scalenus anterior muscle. Okay, this I had discussed. I think we had discussed earlier with respect to level 4 lymph nodes, in which we had said that from the lateral margin of the scalene to the lateral margin of the sternomastoid, anything medial to this is level 4, and lateral to this is level 5. I think that will be it. Next question, Dr. Kosta.
Next is we will go for some vessels. Show us the subclavian artery and the axillary vein, if it is feasible here.
Yes. So we'll start from higher up. This is the jugular. This is the internal carotid with a level of plaque in it. And as we go down, we can see it fuses. There is another similar artery here. This is the subclavian artery. Okay. So it goes towards this. And this is the subclavian vein, which is anterior to the artery. And on other side, we have probably discussed this anatomy in the last class, Dr. Costa. This is the subclavian vein, and the posteriorly is the subclavian artery.
Okay. So next is the some muscles. The teres major and minor.
Teres major and minor. Okay, I will need a different data set, imaging data set. No. Just give me a minute. No, doc, it is not in this data set. Sorry. It will be difficult. It is all cropped up. I can go ahead with some of it. This is a scapula. So this is the subscapularis muscle. Okay. Here. And as we are, these will be on the posterior aspect of the scapula. Okay. So once again, so we are going from above below. This is the suprascapularis. This is between the body of the scapula and the acromion process. This is the suprascapularis. As we sorry,
do you have any kind of thorax? I mean,
thorax. Let me check.
Any data set of anything?
Yeah.
And if not, then leave it. Then we will go proceed to other things. And if it is
I
present,
think
then
I have a case of thorax, but would you give me a minute?
Okay, just we'll discuss.
Yeah, I have loaded it.
Lastly, we'll discuss.
It's loaded, sir.
It's
is
loaded,
is it visible? Is my screen visible now?
Yeah.
Exactly. You can see a thorax, I think.
Yeah.
Okay, so this is a case of a pleural mesothelioma on the right. I think it is pretty obvious. The mediastinal pleura is thickened and nodular. So is the costal pleura. Okay, so we'll go to the part of the anatomy.
Teres major and minor.
Yes, sir. As we go inferiorly, this is the suprascapularis, and then this is the subscapularis anteriorly. Okay, it's a subscapularis, and the muscle that goes inferiorly is a teres major, and then the smaller muscle here is the teres minor. Okay.
Okay. Could you please, show it in the ARF section? I mean, the cranial sections where the teres minor and major is going.
Sagittal. Let's see. Okay, so this is the level of the scapula, subscapularis, suprascapularis, and you have your teres major and teres minor muscles here on the inferior and posterior part of the scapula, inferior to the acromion process. Okay. And
Okay.
what would be interesting, I believe, is the axillary vessels that go through this quadrangular space. I think that is what you're asking for, sir.
Yeah, yes. So, okay, fine. So next we move to the serratus anterior.
Yeah, give me a minute. So the serratus anterior muscle is better delineated because of the lat dorsi. So we first check, this is the lat dorsi, the outer and the posterior most muscle is the lat dorsi. So any muscle that
Latissimus dorsi.
comes, latissimus dorsi, sorry, pardon me. So the any muscle that comes anterior to this on the outer and anterior and lateral portion of the chest wall is the serratus anterior. If you're trying to check for the serratus anterior per se, it becomes a bit of confusion. So always go down below, check for the latissimus dorsi, and then anything that is anterior to this is the serratus anterior, which
Could we
inserts
show
on
the
the
serratus anterior in the cranial sections? I mean, more cranial sections.
coronal section, sir.
Coronal, not cranial, I mean, axial section to the cranial part, more cranial part.
Oh, cranial sections. Okay, sorry. So we'll just trace it. We go from here, we keep tracing it. The muscle goes and inserts on the medial margin of the scapula. This is the serratus anterior. Okay, this one, and that will be all. Okay, it inserts on anteriorly on the ribs from the 2nd to the 8th rib, I believe. Next
so
question.
you are already shown us the subscapularis, and so we will move to now in the brain part, because we need to contour the temporal temporal lobe for the wear purpose. So so could you please show us the Sylvian fissure, the caudal and cranial edge?
I will take you through an MR because on a CT it will be very difficult.
Is it possible to CT?
It is possible to do it on a CT. Yes, definitely yes. So
then please because one thing ultimately when we are going to contour these things now in the temporal lobe, mainly
we will get
we are
CT.
Fusing the MRI or CT fusion might be there, but sometimes the fusion is not that good. Okay. So in those cases, we have to delineate the CT scan only. So
I will beg your pardon. This is not a oncology case. This is just a case of cortical lamina necrosis. This is due to ischemia. Okay, so and this is the level of the Sylvian fissure, the biggest black structure on either side of the temporal area. This is the bone, temporal bone on either side, just medial to the temporal bone is the CSF filled structure, or the Sylvian fissure, where through the middle cerebral arteries and its branches course through. The superior extent is where the operculum of the frontal lobe closes of the fissure, and inferior most is at the level of the temporal operculum, the temporal lobe, where it closes of the fissure. Okay. This is the Sylvian fissure. This is the temporal operculum, and as we go higher up, this is the frontal operculum that closes of the fissure here. Please let me know if I need to be a bit slow, and
fine. Okay, fine. So next we move to the greater wing of sphenoid and petrous part of the temporal bone.
Okay, we will change the window. I think we discussed this window settings last time. Okay, this is manual window is not working. Well, give me a minute, please. It is not showing. Okay, fine, forget about it. So what was your question? Greater wing of sphenoid, right, sir?
Greater sphenoid and petrous part of temporal bone.
Let me see if I can take it. Yeah, this data set is better. So this is a sphenoid bone per se, and this extension on either side are the wings of the sphenoid. This extension on either side. Okay, these are the greater wing of sphenoid, and on which we have our foramen ovale, foramen spinosum. And as we go higher, this fuses with the squamosa of the temporal bone. And the temporal bone has two parts, the squamous part and the petrous temporal part. This is the triangular structure, that is the petrous temporal bone. I think we have discussed the inner ear anatomy and the middle ear anatomy in the last class. This part is the petrous temporal bone. Okay, this triangular area in between.
Okay, fine.
Okay.
And next we move to the tentorium of cerebellum.
I'll have to borrow the image that has not properly loaded. Okay, fine. There's some issue with loading with this image. Can you just give me a sec? Okay. Oh, it's the same. Fine. You want it on the axial image, or would you like to see the coronal, sir?
Axial, axial.
Axial. So whatever structure that comes here, this flimsy line here is the anterior margin of the left tentorium cerebelli. Okay. And this is the supratentorial brain. This is the vermis of the cerebellum. You can appreciate a line here. I am going up. That forms a V. I think it is not. It is more of a appreciation on axial, and this is the vermis again. This is the occipital lobe. So this line that separates the vermis and the occipital lobe, there's a sharp line. I think you can make out that. This is the tentorium cerebelli on the axial. At areas where the folds of the tentorium are aligned along the imaging data plane, we get more of opacity, and at areas where it is less or it is more oblique, then we don't see it much on the axial images. It is just how much structure, how much tissue it has in that data plane, and that makes it visible or invisible. But we can delineate.
Is it possible to show us the cranial and caudal part of it?
Yes, absolutely, sir. This is the falx, posterior level of the falx, and this V is the cranial most part. First V that we see forming is the cranial most part of the tentorium cerebelli. The entire tentorium and the falx form a Y-shaped structure. As we go down, this inserts at the anterior margin of the petrous temporal bone and all along the medial margin of the petrous temporal bone. So this line that is seen on the left but not on the right is the inferior most extent of the tentorium cerebelli. So that differentiates your supra and infratentorial neuroparenchyma.
So last two structure, please. One is the stellate sicca and the parahippocampal gyrus, if it is feasible to see.
Yeah, definitely. So this is the dorsum celli. Okay. And this is the anterior clinoid process. Whatever CSF filled structure is there in between, this black space is a CSF filled structure, is the level of the sella. We have the pituitary at the inferior aspect of the sella, and then we have the sphenoid sinus. So we are going again up, sphenoid sinus, pituitary gland, and whatever little CSF is there in the sella. And next is the supracellular space or the supracellular cistern through which the optic nerves and the supraclinoid segments of the circle of Willis, all the structures here is a posterior cerebral artery and the basilar artery. all these are supracellular structures. I'm going down again. There's a CSF in the cella. There's the pituitary. The pituitary may or may not occupy the entire part of the cella. And then you have the sphenoid sinus. For about your parahippocampal gyrus, it is classically the gyrus that forms the uncus. So the medial margin of the temporal lobe here, it is a parahippocampal gyrus. And for epilepsy studies, the hippocampus and the parahippocampal gyrus are our primary focus of investigation. I think you will be sparing this gyrus, the entire comma-shaped structure, when you're
Is there
taking.
any what will the cranial and caudal structure of the parahippocampal gyrus? Is it feasible to
That
see?
you'll have to check on the coronal dock, and the inferior most part is where you can see the temporal horn of the lateral ventricle, the gyrus that forms around it. You just trace the temporal horn of the lateral ventricle and go posteriorly until this temporal horn comes and fuses with the atrium. So at this level, this is the hippocampus, okay, along the medial margin of the extension of the atrium to the temporal horn. Just at the level of the midbrain, this is the midbrain, inferior level of the inferior colliculus. You can see the upper margin of the parahippocampal gyrus, which finishes off at the level of the midbrain, and then inferiorly again, you can see it is at the level of the temporal horn of the lateral ventricle. On
Okay, fine. Anything? Another last thing I want to one student had been questioned in the previous class that the transverse cervical artery, that is the last structure we are going to discuss today, and
okay,
might be
just a minute.
in the head neck.
Yeah. Is it visible? I have.
Yeah.
Okay. So these vessels, starting from the subclavian artery and just going and lying in the fat plane at the root of the neck. This is the level of the transverse cervical vessels. Okay.
This is the first appearance. Yes. This is the. All our residents want to see this structure. Just this
Okay.
section. So this is the appearance of the transverse cervical vessels from the thyrocervical trunk. So we need to stop contouring the level 4 level 5 lymph nodes in this structure. So
you
that
have
is,
the
I think,
clavicle here, and at the level of the clavicle, you keep searching the fat plane. If you see some branching structure which enhances on post contrast imaging, that is your target vessel.
Okay, thank you, Dr. Shona. Thank you very much.
So much. Thank you so much.
It's very extensive from your side, absolutely, and really, we are really elated to have you in all the 4 classes.
It's an honor, sir. It's an honor. So I hope your classes go on in future, and I will love to contribute whatever little I have in your forum if you're seniors and you permit me.
So
definitely.
This is Dr. Abhishek here. So let me also extend on behalf of the AROI West Bengal chapter very heartfelt thanks to you, because you've not only been there for 1, but you've been there now for 4 classes. And I think the highlight of this course has been the interactive discussion between you and Kaustubh. So my special thanks also goes out to Kaustubh. This session has been amazing. And I again thank you for sparing your time.